PAD are the initials that stand for peripheral artery disease, which is defined by the clogging or blockage that occurs in the arteries outside the heart. When we use the term PAD, we usually refer to artery blockages that occur between the middle of the body and the legs. It's the blood supply to the legs that might be damaged. PAD is caused by the same risk factors that cause coronary heart disease. So blockages in leg arteries can occur simply with aging itself, but are extremely common in individuals who smoke or who have ever smoked, who have diabetes, or when we're exposed to other things that damage the blood vessels like high blood pressure or high cholesterol. PAD is a very interesting syndrome in that, like other diseases, there may be no symptoms at all, or the hallmark symptom of a type of walking discomfort called claudication. Claudication is in some ways angina of the leg muscles. It's a fatigue, a discomfort, sometimes cramping, and sometimes real pain that occurs reproducibly when you begin to walk a certain distance, and that always goes away when you rest. Those symptoms occur in the muscles that are starved of oxygen, not in the bones or the joints. So when a person has walking discomfort that's reproducible in the muscles, one should think of PAD. PAD is simply one of the most common cardiovascular diseases in North America and in the world. In fact, it is pandemic. It affects nearly every family in every country. In the United States, there's at least 8 and possibly 12 million individuals affected, many hundreds of thousands in our state of Minnesota, and recent estimates published in Lancet this year provide an idea that there may be as many as 202 million individuals worldwide. It's very clear from 20 to 30 years of research that of all the things that cause PAD, truly all heart or leg artery blockages, smoking is the single most important. The power of smoking to cause disease is amazing. A woman that smokes has the same risk as a man 10 years older in developing PAD. Smoking cessation techniques utilizing behavioral, lifestyle, family dynamic, and pharmacologic interventions are often successful. There are 3 major goals that every individual with a PAD should try to achieve with their health professional. The first is to stop and arrest the disease progression and to treat the risk factors. The second goal is to preserve quality of life and functional independence. The third goal, which of course is critical, is to avoid amputation. PAD is detected efficiently when the patient and physician in primary care practice first are sensitive to how common it is and listen to the diagnosis of leg discomfort, which should be an important clinical clue. A simple office-based pulse exam is helpful. If there's any question about the pulses being present, one should proceed with a very simple ankle blood pressure test called the ankle brachial index, which is nothing more than measuring the blood pressure with a special device at the ankle and arm. I'm personally very optimistic that healthcare reform in the United States will finally be able to provide an emphasis on prevention and recognizing diseases early. At the University of Minnesota, access to both traditional pharmacotherapeutic or medication interventions, exercise, lifestyle, angioplasty, surgical, and research tools are available at any single visit. We certainly believe at the university that a partnership between our faculty and physicians anywhere in the state, the nation, or the world can be beneficial to an individual patient as well as the community in which they live. We seek partnerships with physicians in practice and other investigators where care can be advanced.